So as briefly as possible, I'm going to give you a quick update on what 2020 has felt like for us so far, look briefly at strategic planning for the next 5 years, and then turn, as we always do in July each year, to finances for the year that starts for us on the 1st of August. Firstly, about coronavirus, frankly, chapeau to everybody in the sector. The way in which the private healthcare sector, the independent hospitals and others, frankly, have responded during this period, I think, has been remarkable and unprecedented. And regardless of anything I've got to say about what PHIN's been doing, I think it must be acknowledged what a contribution has been made in a time of national need. So firstly, thank you and well done to everybody from us. For PHIN, we moved immediately and seamlessly to home working and have remained very productive, and like many others are learning lessons from that about how normality in work going forward may look. In order to allow hospitals to focus on the job that they had at hand, we paused the chasing of data collections. It was still possible to submit data to PHIN, but we weren't chasing anybody for it. And instead, in late March and early April, turned our attention to providing such support as we could to NHS England, NHS Digital and our private hospital colleagues to make sure that the patient level data reporting requirements that we understand quite well, having worked in that space for a number of years, made sense and were actually deliverable, that weren't just a huge shopping list, and were things that could be realistically delivered. And from the feedback we've received, that seems to have helped. I hope that it has. And I think we've also set some really helpful trains in motion in that way that will have an enduring impact. So that seems to have been good. And then for PHIN, actually, we did pretty much exactly what we said to you all we would be doing when we spoke in December. You may remember that we had said for the first half of 2020, you won't hear much from us. We are going to focus on responding to a number of user and member needs that have been raised for improvements to the website, improvements to the portal, improvements in the way that we work. And so we're going to go quite quiet and attend to those internal platform projects, and we'll come back and see more of us. You'll see more of us in the second half of the year. So essentially, that is exactly what we've done, and it's allowed us to be fully productive during this process. So just to recap very briefly, and so far we relaunched our portal completely, and the most notable element of that for most consultants and hospitals at least was a greatly improved login process, which made simple things like resetting passwords far easier. It sounds small, but we want the use of our portal to be as seamless as possible. We are just about to launch a similarly overhauled process for hospitals to submit data to us. A number of you have been part of the final user testing for that and have given us really positive feedback, so I'm optimistic that that will be a really good thing too. We have worked hard on documenting the processing, the methods that we use for processing the data. It's actually a direct obligation in the CMA's order, but more than that, it's just useful to people, and we need absolute clarity on how we do things. And indeed, it's one of the challenges that lays ahead of us as we start to work more closely with organisations like GIRFT and NSIP, is if we've both got properly documented methods, and we can see most easily how we're going to come together to align them. So that work is now just coming to a conclusion. We've been conducting some, for the first time really in our history, some which sounds strange, but some consumer research to inform our website redesign, and we'll be doing a website refresh later in the year. And that's been fascinating. And I've really deliberately used the word consumer there, and I'll come back to why shortly. But we're really starting to understand what people want from information and how they interact with it. And then we did a couple of other projects in the background that sound trivial, but actually create quite a lot of work for us, which is a migration to the latest standards for NHS procedure codes and to the latest version of the NHS Friends and Family test for patient experience measures. There's quite a lot of planning and execution involved in those tests, not least because you have to accept that a period of time people will be submitting data to us in two different standards. and think about how that's communicated, reconciled and managed through. But we've done that. And so very briefly, for the remainder of 2020, we're aiming for the publication of the never events information that we delayed from the tail end of last year in September, following there's a data refresh due at the beginning of September, so we'll aim to publish never events then. All of the hospitals who have never events showing are being particularly contacted and are fully aware of the never events that they have, to make sure that everybody's fully prepared for that. So hopefully we'll be able to go forward. Speaking to some of the insurers in the room, particularly who've quite rightly pushed us for this in the past, but there are many audiences for it. The work that we're now completing on documentation and processing of methods will allow us to recreate the downloadable version of our publishable information, at least at hospital level, we think from September. Again, following that next data refresh and final checking, so we aim to get that back out and into people's hands. And again, just to remind everybody, that is information that is already in the public domain via our website in a much more consumable form. We know that people are already scraping it from our website using those kind of technologies. It actually can slow our website right down, to the detriment of consumers. So we want to make that as convenient for people as possible. And then some of the things we've already talked about, like the ADAPT pilot, we'll need to keep working on that. We aim to launch a programme, actually in conjunction with the London School of Economics, from about November, to look at a PROMS refresh. PROMS hasn't gone entirely smoothly in implementation to date, so we want to look at the barriers and enablers to PROMS and see if there's anything that we can do to simplify the programme or help people to move forward positively with that. And of course, we're aiming to bring a strategic plan to finalisation sometime around December. So before I move on to the strategic planning exercise, is there any questions that anybody would like to raise simply on what's happened so far, or the remainder of this year? So strategic planning, I'm going to start with a mission statement. There were mission statements contained in our last strategic plan, and we want to keep this one sort of fairly straightforward and understandable. PHIN has a core mission, and it is about producing great information about private healthcare and seeing that information used as widely as possible. That's our agenda. There's nothing more to it than that. And when we say used as widely as possible, we mean by patients stroke consumers, I will come back to that, to understand options when they're choosing healthcare. It has to be used by healthcare professionals, providers and regulators to continually improve and monitor care. And that is absolutely inherent in what we're going to talk about in terms of a response to Patterson and the work with GIRFT and NSIP, of course, and also by GPs, policymakers, funders, insurers, and everybody else who plays a part in the system, for whom nobody has a complete set of data about private healthcare. For many audiences, the understanding is limited, and we think we definitely have a role to bring a greater level of understanding to things. Now, essentially, I'm framing this as a mission for something which is largely within our control, is very consistent with, but not entirely limited by, our role as a CMA's approved information organisation, and should be entirely recognisable to members. But then to take another thing which should also be recognisable to everybody by now, we've already been talking about it, we think that sits in the context of a larger vision. I'll come back to that. So just very briefly on patients and consumers, we think people are both. But this distinction, this wording, seems to get people quite exercised at many stages. And consultants often remind us, please don't talk about consumers, they're patients. The CMA's order, however, is very much framed as consumer protection. And we think it's vital to recognise that people are both. And we're recognising the work that we've got to do for both aspects of people's journeys. Now, people are consumers, in our view, when they're searching and choosing routine care. And what the research is telling us is that they need simple, clear information and clear routes to action. They want to come on, they want to understand the options very quickly and very simply without too much information. And they want to take action, they want to move forward. On the other hand, we absolutely know that patients, as care progresses, fundamentally trust in the medical professionals and providers. They're probably less seeking of information at that point. But in the final analysis, they expect the data to be there, to be used on their behalf to protect them and promote patient safety. And that could never be shown more clearly than by the Patterson Inquiry and Cumberledge Review that have been published over the course of this year. In both cases, the experience of patients was listened to, and in both cases, information and the lack thereof has played a very significant part in the observations and recommendations of those two reviews. So we have to listen to that. And perhaps we're looking at, as PHIN, an overall journey from a focus primarily on consumerism previously to one more based around patient safety and patient protection in the future. And just to pick up on one particular aspect of that that really echoes the comments made by Tim and frames a lot of what we're doing, I'm just taking this one quote from the Patterson Inquiry report. We were told that if there was more accessible data about a consultant's whole practice, then the events described in this report would have been stopped more quickly. And I don't think any of us need better motivation or reason to start thinking about this area and making some real changes in the way that information is produced than to create a comprehensive and meaningful response to that. So the bigger vision and bigger goal than PHIN really just takes the work that we're doing already and places it in that context. We're about great information for private patients, but we need to look much more broadly at great information for all patients. And that brings us back to the ADAPT vision that Richard referred to earlier, that there should be ultimately one standard and one system for collecting data and measuring quality for all care delivered in England, whoever pays or provides. And firstly, I will note that I've said England. PHIN's remit is UK wide, but please let us start where we can start, and we'll undertake to take that to the other nations as and when we can. This is fundamental to a comprehensive response to Patterson. It's definitely a component of improving data on medicines and medical devices that comes out of the Cumberledge Review. ADAPT is the mechanism, and NHS Digital, GIRFT and NSIP we see as partners, where the role for GIRFT and NSIP is absolutely about taking this to a practical, ongoing level. It's about surveillance, not just audit. It's about actually doing something with the information to promote meaningful change as we go forward. So we're proposing a simple 4-part strategy for the next 5 years. And I should say that the stage that we're at the moment, this isn't the strategy. This is a set of proposals and issues guide, if you will, for members to engage in, for the public to engage in, indeed. I don't think the strategy should be focused wholly internally to the industry, quite the opposite. I think we have to have something to say to the world beyond. But this is the simple 4-part strategy that we think we need to take forward. So number 1 has to be accelerate and complete delivery of the CMA's requirements. Number 2, focus on delivering benefit to patients. Number 3 is create some value for stakeholders as we go forward. And number 4, currently consuming most of my attention, I have to say, is work collaboratively and effectively towards one system of healthcare as we've described it. And I'll go into a bit of detail on each of those, but still only quite briefly. And just to say, 4 years ago, we set out a series of values for PHIN, more priorities actually than just values, which were to be trustworthy, informative, responsive and effective, starting with trustworthy because we are the guardians of data in the sector, and that's quite a responsibility. Informative is why we're here, responsive is how we work, and as is effective. And you'll note that our 4 strategic priorities map neatly to those. And so let's start with accelerating and completing delivery of the CMA's requirements. To my mind, that is essential for maintaining trust and credibility in private healthcare. We've been doing this now for a few years, and we've made some really good progress. but we've still got a long way to go, as we've often acknowledged, and currently the rate of progress is a bit slow. But getting to the sort of information that is inherent in the CMA's requirement is absolutely a building block for everything else that follows, for that cooperation with our partners, and for coming up with a more comprehensive information solution for the sector going forward. It's actually, frankly, more relevant in those contexts, probably, of patient safety than necessarily in consumer choice, being blunt. But we can't avoid it. I think anybody objectively looking in would say, yeah, well done for making some progress and getting something off the ground, but when is it going to get finished? When are you really going to have every prescribed measure for every covered procedure for all hospitals, for all consultants on your website and generally in use? How quickly can you get there? And of course, that's a question which needs real discussion over the next couple of months. We really need to think about what time frame is acceptable and balance that against the resources required to get there. But without doubt, if we're going to accelerate, and I think we must, it will require some recommitment from everybody who's already worked very hard and is currently up to the rise in COVID as well, and inevitably more resource in all areas, not just in PHIN, but across the whole supply chain, I think. And it will require some fresh approaches and some fresh thinking, hence why we aim to look at problems, barriers and enablers and revisit that programme a little bit. We want to talk about fees and prices and how we make sure that we're actually producing meaningful, relevant information for patients as we go forward, not just publishing things within a fairly narrow confines of how perhaps the exam question was set. And we certainly need to look at things like the rate of consultant participation, acknowledging that whilst it's fantastic that we've got over 6,000 consultants signed up providing their fees and getting on for 3,000 having signed off performance measures, which is more than there's ever been previously, that leaves us an awfully long way to go. And currently the rate of increase is slow. So we'll definitely need to look at new ways to address that question. So, secondly, a focus on delivering benefit to patients. That's got to be what it's all about. It reflects the shift that I've described to you over the last year or so, that we're moving from 5 years of building infrastructure and relationship and data flows. So from data in to information out. We've been about getting data in. The next 5 years is about getting information out to patients. Moving from that competition and consumerism as the main driver under the CMA's order to an equal focus on patient safety and promoting that. For consumers looking via our website and other channels, and for patients via this comprehensive system of improvement in partnership with others. And I think it's important to realise that you could go through the CMA's order, as we could as a sector, essentially paying lip service to the order part of it and doing exactly what it says in black and white, and not being found to be not compliant with the order, and going forward on that basis. But that would be a real shame. We believe a purposive interpretation is required, as lawyers put it, i.e. we ought to imagine that the CMA intended us to actually achieve something, which they clearly did when you read the report, which means consumers finding our information, using it, making better choices, and in so doing, making the market more competitive and more successful. And that needs to be our measure over the next 5 years. Not that we're just producing the information, but that people are actually using it to have a better experience of healthcare. And we also need to be brave enough, I think, to ask patients what they actually want and then deliver it. I've been very wary to ask patients what they want for a number of years, not least because I felt constrained by the CMA's order to doing a prescribed set of actions. But we're going to have to be brave enough between us to ask them what they want and then collectively sign up to giving them what they want. Otherwise, there's no point in asking. Next thing is to, as we go, create value for stakeholders. Look, patient and consumer interests always come first. Trust, independence and integrity are always vital. And if there's ever a conflict between the interests of patients and the interests of participants in this endeavour, then the interests of patients come first, let's be in no doubt. But there's nothing to stop this working for members, and indeed it will work far, far better as an endeavour where everybody gets something out of it and interests are aligned. That's inherent in a competitive market. It's intended that patients use the information well, that make good choices, that providers and consultants benefit from that, provided they're offering good quality, good value care. And we also need to create more broadly a public value through the one system approach. Now, I'm just going to take a moment, and this is offered in the spirit of stimulating conversation, just to look at what we might mean by value. And I'm going to say in advance that parts of it might initially strike you as controversial, but the two ends of a spectrum that I'm going to start at are the most obvious. The first is where we've largely been to date, which is to look at what PHIN's been doing as a compliance exercise to make sure that everybody was doing what they needed to do under the order. And it's quite easy to put a financial value on it because essentially it's directly equivalent to the cost of operating. That's the basis of PHIN calculating subscriptions. There's a bigger cost than that within the sector as a whole, of course, but that's really the cost and indeed the value of that compliance solution. At the other end of the scale, I think it's also relatively easy to see what the overall benefit might be, and the thing that we have implicitly been aiming at all the way through, but we need to bring into a bit more focus. And that is simply that in a market worth £5 or £6 billion per annum, small changes in the perception of reputation and people's consequent propensity to buy can have significant numbers attached. You know, plus or minus 1% deviation is £50 million either way, which could be a spread of £100 million per annum in the market between doing our job not very well, but only mildly, or doing it quite well, but again only mildly. And the differences could be much bigger than that if we all approach it with due endeavour. And then there are further steps that we would be happy to explore. Clearly, in producing PHIN's data, we produce, or managing PHIN's data, we produce information that has a value back into the sector as market intelligence, as the shared resource we've always wanted it to be, the one version of the truth within private healthcare that talks about activity and quality and is there to be used by consultants, by hospitals, by insurers, as well as by the public. The sector as a whole, as far as we can see, doesn't spend an awful lot on that kind of market intelligence at the moment. I might be underestimating. There's a benefit to be had there, but it's not huge. We think there's an opportunity to address shared services and capabilities to a greater extent than we do, to reduce duplication within the sector, to make things much easier between members and PHIN in terms of interaction, to do things once which are currently done many times over. And that has a slightly larger value, probably bigger than the value of the work we're doing now. And in particular, if members are paying a certain amount to us each year, the total cost of even doing compliance when looked at across all members might well be £8 or £9 million per annum across all hospitals. And I'm certain that there are things in there where there is unnecessary duplication between organisations that we could streamline and help to add value. And then sorry, I'm going backwards. The last part in there is one where we have absolutely no intention of commercially exploiting this at all, but I want to put a value on it anyway. And that is the value in the data asset that we've created by doing what we do. And just for a quick illustration of that, Ernst & Young, the global accounting firm and consultancy, valued NHS data last year at £10 billion. In combination of about £5 billion worth of commercial value and £5 billion worth of realisable, improvable value to patients and the public sector in terms of things that could be achieved with the information. Now, the private data we hold isn't on the same scale at all, but it becomes an interesting question to say, well, what is the value of the data that we hold? Is it 1% of that, i.e., £100 million per annum? Is it 0.1% of the value of NHS data, albeit we represent about 8% of the patients? Who knows? But for the sake of the argument, we're going to say that there may be a data value of around £10 million that we've created. And the reason we say that is not because it has it's commercializable. It isn't. It would be illegal for us to do anything commercial with that underlying data, but more to recognise as we go forward and make sure that our members are comfortable with what we're doing with ADAPT. I hope we are, because essentially we are giving that away. We are taking that asset that has been created and we're proposing to put it into the public domain through the ADAPT programme in an open data spirit. We think it's the right thing to do, but we certainly want to involve members in the dialogue to make sure that everybody's comfortable with that as part of what we're doing. So I think you've probably heard enough from me now about pursue collaboration and system efficiency when it relates to the public sector. Just to say, I think there are still opportunities as well internal to the sector. Some of the opportunities are illustrated by initiatives like IHPN's Consultant Information Sharing System, or SIS, approach. I speak regularly with Health Code, and there remains significant overlap between those two organisations, and therefore potential for doing things once that are done often. A good example to this that would occur to all three of those, Health Code, PHIN, and potentially SIS, is the need to interact with thousands of consultants across the country. Health Code have built a substantial team to do that. We have a tiny but hopefully effective team within PHIN, which definitely needs scaling up as we go forward. So the question becomes, okay, are we going to scale up to a similar extent that Health Code have already built it, or can we work together? And certainly raises the question, if SIS goes forward as an entity, how do we make sure that we don't build a third approach to that engagement, all of which effectively are talking to the same consultants on behalf of the same sort of players in the market? So there's opportunities, I think, to pursue there. PHIN has also grown up enough at this point that we can consider outsourcing selectively again and partnering commercially, in as much as we spent years now bringing, we started off with everything outsourced, we brought things in-house, we've established a high degree of control over things now, and that might allow us to do selective outsourcing going forward, hence why we're involving parties like London School of Economics, but we're also talking to parties like Dr Foster and CHKS, Grant Thornton and others, just to see if they have skills and capabilities that we could buy rather than build as we go forward. And just to remind everybody, I think you've seen this diagram before. These are the 5 key domains for PHIN. We gather data, we process and analyse that data to produce information, we publish that information. We have to have outstanding governance throughout to do that. We have to engage with a wide range of stakeholders to do that. The governance and engagement, I think, remains very much on us, but those aspects of gathering data, processing and analysing that data and publishing the information are precisely why we are looking at these range of partnerships, to make sure that those are being done where they're done most effectively and efficiently, done once where they can be, collect the information once and use it often as the principle. And that will simply allow PHIN to focus and become excellent in the areas which it must do, by stepping away from some of the areas which somebody else can do more effectively than we can. So, going to take a quick pause. I won't invite questions just yet, though. I'm going to talk very briefly about finances and then engagement, and then that will lead us into questions. So I hope you're all still with me. Finances, I'm going to keep it simple. Firstly, briefly, this is not the AGM, so this is not audited accounts. But at the beginning of this year, we quite deliberately didn't raise our fees. We applied a very small inflationary uplift of whatever prevailing inflation was at the time. It's smaller now. We budgeted for a small loss in year. We didn't make a small loss in year. We've made a very small surplus. That's partly due to financial management, and it's partly due, frankly, to the pandemic, which has slowed down spending on things like meeting rooms and travel. Again, a lesson for us going forward, which means that for the first time in a while, our reserves are close to our 6-month target. And hospital members who bear the costs of PHIN will be pleased to know that as we go into 2020-21 on the 1st of August, we've signed off a budget this morning that again says no substantive rise to fees. But I should say at this point that is essentially recognising that we're in the middle of the COVID-19 pandemic and that everybody is facing an uncertain financial situation at the moment, and it would just be wrong to do anything other than hold fees where they are as we go into the next year. So I hope it reassures people that we'll be holding them steady for a while. That will mean we'll be budgeting for a small loss to be absorbed by reserves in the year ahead. Hopefully we'll be able to manage our way out of that again, but we've just signed off a budget with a small loss against the annual income. But what that does mean is that as we approach 2021-22, so this time next year, hopefully we'll have our strategy in place, having consulted through with members and got it signed off by members and the CMA. And at that point, I have to say, I think finances will need a fairly major reconsideration. We'll hold up our hands and say, I think PHIN in combination with the rest of the sector probably underestimated the scale of this endeavour a few years back, and we need to collectively take a view on what it really requires to do this job properly and within an acceptable time frame over the next few years. And also we are trying hard to pursue these partnerships and the larger vision which we think is to the benefit of patients, definitely, and to the wider private healthcare sector as we go. And we've been carrying the costs of doing that internally so far, but there are costs to it. And at some point, we will need to think about that sensibly. Now, those costs hopefully are mainly short-term costs because they're more program oriented, but to do our core job, do it well and get it done quickly, those are probably slightly more enduring costs, and we'll need to have that conversation as we go. So finally, just looking ahead to engagement, we're going to circulate an issues paper to aid dialogue in early August, saying similar things to what I've said today, but with a bit more detail. And I apologise in advance, lots of words and quite a few pages. This is now quite a complex endeavour, and there are a lot of sensitivities around it, and we've tried hard to shorten it, but there's quite a lot to say. So apologies for that, but I think it's necessary. We'd like to finalise a strategic plan for the coming 5 years at our December AGM, but we're also very aware that you all remain deeply engaged in the work around COVID and the recovery for both the NHS and private sector that will follow it. So we're going to have to be realistic about the amount of time we can ask for from all of you, from your teams, but there's a lot to cover. It needs the dialogue and input of members and stakeholders, ideally patients. And I put the word investors there, and I choose that deliberately. PHIN doesn't have investors per se, we don't have shareholders, we're a not-for-profit organisation. But in the same spirit that I pointed out the value of the data asset we've created earlier, the hospitals in particular who funded PHIN's existence, but to an extent all members, everybody who's been on this journey with us has invested significantly in creating PHIN so far. And we've been on the journey effectively of a startup. You know, we're 8 years old as an organisation, 5 years into the CMA's mandate. And I do speak to private equity houses and other people in that sort of world of things, your health investor type audiences from time to time. And it reminds me that we are a startup, and we need a dialogue with you folks sometimes as investors in the future of this, as something that you put your time, put your money into, and need to get the best out of, even if it's not a financial return, to get a practical return in terms of the information dividend and the benefits that can bring. And to put it bluntly, I think we've proven our case over 5 years and done a pretty good job with our Series A funding, and it's run out. And now we need to talk about Series B and where we can go from here to take things forward in the dimensions that we've discussed. So key period for this, if we were going to get it signed off by December, would be September to October. We're thinking now about how best we do that engagement, how we manage group and individual interactions. We will reach out as far as we possibly can, but also please do get in touch. Again, we're constrained by, there's a finite number of me and the team to go and do this engagement. We would love to spend time with everybody. It's subject to your availability, it's subject to ours, but we will really try to reach out to everybody because it's vital that we talk through all of these things. There's not going to be a huge amount of actual change to the way we do things over the next few months, but it's vital that we have these conversations to enable change in the future. And then the one final thing that we will need to do, and the reason in particular that I asked Richard and Tim to present at the beginning of this meeting, is there is a requirement in the order quite properly that we must actually get the formal approval of members before sharing data in any way. And so we will need at the appropriate time, once the ADAPT consultation's out and has been understood formally, and with GIRFT at the appropriate time, to come back to you, possibly at the AGM, possibly before, to actually ask for formal sign-off of the data sharing with ADAPT and possibly with GIRFT, and therefore we're asking you to engage in those.